So good evening, everyone, and welcome to the second day of Dundee FRCS course. And we will have four presentations today. Two of them will be delivered in live, and two of them will be recorded. We will start by the most important topic, which is one of the most important topics. It's rhinoplasty for FRCS. So ask Mr. Rangasan or Ragnasan or pass to start. Thank you very much for being here, and I will hand the microphone for you.
Thank you, Ahmed, and thank you, Jay. So my topic is on rhinoplasty. So I'll spend about 20 to 30 minutes. We'll go through, how do you assess the patients and how do you plan the surgery, and so we'll go through some of the case scenarios as well. So it's like any other, you know, uh, scenario, it'll always start with the patient selection, especially this is the most important bit for the rhinoplasty. Okay. This is not only for your exam, it's even for your practice. This is the most important. You always, start with an open question, let the patient talk. You just go with an open question. What's your main concern? What changes you're hoping for after, from the surgery? Okay. And during your consultation, find out what is the motivation for the surgery. You don't need to sometimes directly ask them, but you can hint and why they want now, why they had the problem for a long time, why they want now, is there any particular reason? So I think it's good to understand their motivation behind why they want the rhinoplasty surgery. And especially in the NHS, we don't do any cosmetic surgery, but it's mainly a functional septal rhinoplasty. So I think now it's mandatory to do, get the nose questionnaire. That's to assess the nasal obstruction, the functional aspect of the issue, and also ask them whether they have any other associated sinonasal symptoms, like if they have any chronic sinusitis or polyps. It's best to treat that first before doing a rhinoplasty. Yeah, and the other important thing is what's their expectation on the psychology. Okay, this is much very different from any other clinical stations that you'll come across. Okay, here it's like a rhinoplasty is called like a psychosurgery. Okay, half is your skill, surgical skill, and the other half is understanding the patient's psychology, their expectations. Okay, you define your limitations, what you can achieve by the surgery. Better not to overpromise. I always prefer under promise and over deliver. Okay, tell them that I'm not going to get it perfect, but when you do the surgery, you do everything to get a natural looking nose. And the other important thing is um, screening for body dysmorphic disorder. Okay, this is very important for rhinoplasty. um, the reason is at least 20 to 30% of the patients who are seeking for rhinoplasty may have an underlying body dysmorphic syndrome. So we'll go through that a bit later. Yeah. So I think that's important. And, you do the documentation. That's really important. Take pictures, document everything, what you've discussed, and then see them back again. Okay. 2 appointments at least, see them back in 2 or 3 weeks' time to go through the consultation, and take them through the surgery in detail. So what are the red flags? So in rhinoplasty, more than when to do or what to do, it is also important, when not to do the surgery, when not to operate, offer surgery. This is very, very important. So patients who are not really engaging with you, you get that sense when you're talking to them. And those who have that really, an inflated expectation. So I want a perfect nose, bringing some pictures, asking them, I want this angle to be corrected. I want this, the tip to be refined. All those small details when they ask, your alarm bell should be ringing. Overly demanding and body dysmorphic syndrome, as we discussed, those who had multiple previous surgeries, going from one surgeon to another surgeon, trying to get to perfection, they're not the best patients for you. Those who are really rude in the consultation, they're not going to be kind when something goes wrong or there's a complication. At the same time, when they come and say that you're the best surgeon, don't believe that as well. Okay. And patients, we see many patients with the cocaine use now. So very mindful about it. Examine the nose. When you have any suspicion, do a urine drug screen. Don't hesitate. So what is body dysmorphic syndrome? As soon as you utter this word, I'm sure the examiners wants to know, what is body dysmorphic syndrome. So you need to come up with a two-line, like a definition. So it is a psychiatric disorder. Okay. Patients are either preoccupied or obsessive with even the slightest deformity, or there's no deformity at all. Okay. And they have a very negative thoughts about their body image. They're constantly, frequently checking the mirror, and they feel that the whole life is ruined because of that nasal deformity. Okay. So you get those things, like during the consultation, when they start saying this, I'm not going out, I'm not socializing, I can't do function, all because of this. Then you need to think about body dysmorphic. As I said before, you know the patient's population with the body dysmorphic syndrome is quite high in patients who are coming for seeking rhinoplasty. How do you screen? One is getting this, when you're doing the consultation, you'll get a feel of it. But there are some questionnaires that you can use. Body BDDQ is a body dysmorphic disorder questionnaire, and then the Utrecht questionnaire. They're useful tool, like, it's like a screening. There's always a high sensitivity, but at least it just flags, and you may want to refer them to a psychologist to assess the patient, so whether they have any BDD. And if those who have a BDD, you should not offer any surgery, okay, because it's a cognitive problem rather than a structural problem. They may have some functional issues. Not to say that you can't do surgery at all, but you need to involve the psychologist, psychiatrist, go through everything. And if they have a genuine functional problem, then you can offer the surgery. But I wouldn't definitely do any cosmetic rhinoplasty in patients with the BDD. Yeah. So preoperative documentation, really, really important, because a high, chance of legal issues with the rhinoplasty. Okay. That's why the indemnity is quite high for a patient, for those who are doing cosmetic rhinoplasties. So good counseling, clear documentation, provide physical return leaflet, and document that you provided the leaflet, and also document that you have, patient has read the information leaflet. Consent form, write all this important complications. I write this in all my consent: infection, bleeding, septal perforation, numbness, skin changes, revision surgery, bruising, loss of smell, unsatisfactory result. These are definite actually for any rhinoplasty in my practice. Okay. And also document clearly that the patient has realistic expectation. Okay. They are looking for improvement, not perfection. So I document that in every patient that I do rhinoplasty. So coming to an assessment, you need to have like a mental algorithm to how to assess the patient for the rhinoplasty. Okay. I don't think in the exam you're not going to get a rhinoplasty surgeon who is sitting in front of you to asking the question. So it might be a general ENT consultant who might be sitting. So they're not expecting you to say each and every deformity and expecting, but as long as you have an algorithm in your mind, so you go systematically, I don't think the examiner will mind, and they will like it. They may not ask you any more questions. Okay. So this is my algorithm, but people do differently. I always start with the facial symmetry, and then the front view, profile view, basal view, and then the palpation. This is about the palpation. Look for the skin thickness, tip recoil, and look at the septum. Examine the internal and external valves, and complete your examination with a nasal endoscope. Okay, we'll go through this in detail. Okay, so facial proportions. So it's a horizontal third and vertical fifths. This is pretty straightforward. I'm sure you're all aware of it. What you're looking for is any obvious facial asymmetry. Why it is important? Again, you need to document that in the preoperative, because the nose, you may correct the nose perfectly straight. Because of the asymmetry, it can give you an illusion that the nose is tilting to one side. Okay, so patient may complain, I still look at the mirror and my nose is tilting. But you need to pre-warn them that, during the consultation, that, you got a facial asymmetry. So it'll always look that the nose is tilting to one side. So you pre-warn them, then the patient understands that. So horizontal thirds, vertical thirds. Hope I don't need to go through in detail. And then the anterior view, look at the patient in the front view, divide the nose in thirds, upper third, middle third, and lower third. Upper third roughly corresponds to the nasal bone. So what you're looking in the nasal bone is there any deviation? Is it wide? Is it symmetrical? And then coming to the mid third, is it narrow, wide, or is there an inverted V deformity? We'll discuss that. Okay. And then looking at the tip, that's the lower third. Looking at the tip, there are different types of tips are there. Tip are there, like bulbous tip, boxy tip, very pinched tip. And then look at the alar rim, is it retracted, and look at the alar base. Is it really wide or is it narrow? Again, that will, vary with, with the different ethnicity of the patient. And then look at the lateral profile view. Again, you divide the nose in thirds, upper third, middle third, and the lower third. In the upper third, what you're looking is the nasofrontal angle. That is between the nose and the forehead, the angle. And then the radix is the upper part of the bone, the root of the nose. Is it high or is it low? Okay, this will make a difference in what you're doing. Mid third, again, what you're looking for is there a hump? Is there like a saddle deformity? Okay, like a depressed mid third. And then coming to the lower third, that is the tip of the nose, what you're looking is the projection and rotation of the nasal tip and the nasolabial angle. In the profile view, we discussed about the projection, okay? So they may ask you, there are different methods of assessing the nasal projection, but the most common one is a good method, okay? That is the distance between the alar facial groove to the nasal tip and the distance between the alar facial groove to the nasion, and the ratio should be 0.5 to 0.6, okay? Okay, if anything more than 0.6, then it's over projected. Anything less than 0.5 is under projected. Okay, so that's about the projection. Okay, and then coming to this angle, it's a rotation of the nasal tip. Yeah, so whenever you're describing the projection, it is over projected, under projected. Okay, when you're describing the rotation, again, like it's over rotated or under rotated. Yeah. So this is different in men and female, in men and women. Men, it is more acute. It's 90 to 95 degree, the nasolabial angle. And then, it's deep as well. The nasofrontal angle is deep, 115 to 120 in men. And more obtuse in female, it's 120 to 130 nasofrontal. And then it's slightly over rotated. The nose is the tip is slightly over rotated. So 95 to 105 degrees. I think, there are so many angles are there. You don't need to remember any of that. I think if you could just remember these two angles, that's more than sufficient for the exam. So we discussed that, the rotation, whether it's increased rotation, decreased rotation, and projection, is it over projected or under projected? And coming down into the columella, you can, patient may have a retracted columella or an overhanging columella. Okay. So how do you measure that? That's the distance between the alar margin to the columella. If the distance is more than 2 millimeter, or more than 4 millimeter, then it is a hanging columella. Okay. Or if it's less than 2 millimeter, then it's a retracted columella. It could be a combination of either the nostril itself or the alar itself is retracted, or sometimes the columella might be hanging too far. Again, it's a bit more complicated. I don't think you need to know for the exam. If you just say whether it is a retracted columella or a hanging columella, that will be more than sufficient. and looking at the alar base, which roughly corresponds to the medial intercanthal distance. Okay, but again, this is different from different ethnic group. Like, in Afro-Caribbean ethnic population, they may have a wider alar base. That's the natural way. In Caucasians, they may have a very narrow, less than the intercanthal distance. Okay, but roughly this is, that's what you need to know, whether to say whether it's a wide alar base or a narrow alar base. And also you can, when you're looking at the base of the nostril, you can look at the symmetry of the nostril. Okay. Coming to assessing the airway, you need to know what is internal nasal valve, what is external nasal valve. Okay. Internal nasal valve is, I'll just see if I can move this away. Okay, the internal nasal valve is the angle between the lateral wall, septum, inferior turbinate. So this angle should be about 15 degree. Anything narrow, it causes narrowing of the internal nasal valve. External valve is what you see here. Okay, it's the alar that is collapsing. Whenever they're breathing, the nostril is collapsing. That means there's a structural weakness of the lower lateral cartilage. So that's what causing the weakness, with the floppiness or the weakness of the alar of the nostril. Okay. How do you assess them? You do, ask the patient to breathe, normal breathing, and then forced breathing. Just observe the movement of the nostril. Okay. So that is the dynamic collapse. If the patient is forced breathing and if everything is collapsing, it's called dynamic collapse. And also you can assess use the Cottle and modified Cottle's technique. Okay. So Cottle's technique is pulling the cheek away and ask the patient to breathe. If that improves, that means there's narrowing of the internal nasal valve. And the modified Cottle's is use a Jobson probe. You can assess exactly where the narrowness, and you lift the nostril, use a Jobson probe to lift the internal nasal valve or the alar of the nostril and ask the patient to breathe. If that improves, again, that indicates the narrowing of the valve. And then, you're going to do a basic anterior rhinoscopy with the thoracum speculum, look at the septum, is there a deviation, and look at the turbinates. And you complete the examination of the nose using a nasal endoscope. Look at the mucosa. Is there an infection, polyps in the middle meters? And it's very important to examine the postnasal space. Okay. Septum, when you're looking at the septum, there's a famous saying, as the septum goes, so goes the nose. Okay. And that's very important. You correct the septum and, you correct the deviation of the nose as well. Again, it's important when you're assessing whether the deviation, is it on the cartilaginous aspect of the nose or is it on the bony aspect of the nose? Yeah. Good. And then, palpating the nose, what you're looking for is it a thick skin or a thin skin? Okay. The thickness of the skin varies in different subunits of the nose. Okay. It's always quite thick around the tip of the nose, and around the radix it is thick, but it's very thin over the nasal dorsum. Okay. So it's important to assess that. Why it is important? Thin skin, it heals really well, and you can get a very predictable outcome. Okay, for this patient, you can see on the top, came with a dorsal hump. You reduce it, you can see that it looks nice and clean, and you get a very precise outcome. Very, when I say precise, it's a more predictable outcome. But the downside is if there is even a small irregularity, it'll be very visible. Okay, and also they heal very quickly. Thick skin is like a thick carpet. Okay, it just hides away the small irregularities, but it takes long time to heal. Generally, we say about 12 months to see the outcome of the surgery. But in thick skin patients, I may say that 12 to 18 months actually. And you may not get the perfect definitions, especially around the tip. So you may have to use more structural grafts to get the definition. Okay. So I think that's the difference that you need to know, whether it's about thin skin, thick skin, what are the advantage, disadvantage, important. Okay. So that's about the assessment. Again, like, going through, look at the, if somebody shows a picture, look at the facial symmetry, and then look at the front view of the nose, look at the upper third, middle third, lower third, profile view, upper third, middle third, lower third, look at the basal view, look for any look at the alar base, nostril symmetry, any tip rotation, and then you say that you want to palpate the nose to assess the skin thickness. Also, you can say that, the tip recoil, like, whether they have any poor tip support. Some people palpate the septum also to assess whether there is any deficiency in the cartilage. And then you're going to ask the patient, you're going to assess the internal and external nasal valves for breathing, and you complete the examination with a nasal endoscope. Okay, so some case scenario, you can see this is quite an obvious saddle nose deformity. They may just, sometimes in the examination, they may not show all the pictures, they may just throw one lateral view. Okay, then, that changes the scenario. Like, you can't go through all the facial symmetry, you can't ask for it. But you can say that ideally, I would like to, have the other views, like anterior view, lateral view, basal view, to examine the facial symmetry and then, go through. But given that here just only a lateral view is available, you can say two ways. You can say one is, okay, patient, here is a medical photograph with an obvious, saddle nose deformity. I think it's better to describe what the saddle deformity is. If I were like, I would say, in this patient, he's got a significant saddle deformity with a pseudo-dorsal hump, columellar retraction, the tip is over-rotated. Yeah, that's what I would say. And then I would say that this is a classical, definition of a severe saddle deformity. Then they can ask you, why this is saddle deformity. It's a septal framework support, loss of septal framework support. And you lose that L strut, yeah, L strut support, then the nose starts collapsing, okay? And there's also the contraction of the skin and the soft tissue envelope, which causes the saddle deformity. What are the causes? The most common ones are the trauma, previous septoplasty, over-resection of the cartilage leading on to saddle deformity, or big septal perforation eating away the L strut, and that loses, the nose loses that support. What you're going to do with this, again, you discuss, conservative management, and then the surgery. What surgery you're going to do? You're going to reconstruct the nose. So what they want to listen is, here is an augmentation rhinoplasty or a structural rhinoplasty to augment the nose. Okay. So that's about saddle deformity. The other scenario, common one, is like, they may just put this one anterior view with a inverted V deformity. What is inverted V? That is a disconnection between the nasal bone and the rest of the nose. So that is the upper lateral cartilage is disconnected from the nasal bone, which is causing this inverted V here. You can see the inverted V here. Okay, that's a mid-third collapse. Very common after rhinoplasty or severe injuries. Okay, very common after rhinoplasty, because sometimes when they do like a hump reduction, that's the most common indication for rhinoplasty. When they do a hump reduction, if you don't reconstruct the mid-third, patient will start developing this inverted V deformity. One is it's an aesthetic, and the other thing is like, they may have a very narrow internal nasal valve. You can imagine that the upper laterals are just collapsing into the nose. So that causes severe breathing problem as well. And how do you address this? Again, reconstructive rhinoplasty. You reconstruct the mid-third using spreader grafts between the upper laterals and the septum, and you rebuild that and provide that support here. Okay, so that will, one is aesthetically, it will look better, and also It will widen the internal nasal valve angle. Okay. Some of the key discussions, when you say surgery, they can ask you what you're going to do, like whether you're going to do an open or a closed rhinoplasty. I don't think there's any wrong in saying, whether it's open or closed. It's all about your training. Okay, most of the rhinoplasties can be done by closed approach or an open approach. 95% what I do is an open approach because that's what I'm comfortable, that's what I was trained for. But it's about the individual preference. There's no right or wrong answer. But generally, if somebody's got a revision procedure or a significant reconstruction that you want to do, like a saddle nose or the inverted V deformity, then open approach would give you better access, and you can use the structural grafts much in a more controlled way. Uh, then they may ask you about, this when you say augmentation rhinoplasty or reconstructive rhinoplasty, they can ask you what are the graft materials that you're going to use. The most common one, if the septum is available, that's what will be your first preference. Conchal cartilage is another option, but not a great option. Okay. Costal cartilage is the best. Okay. If you don't have enough septum, then the rib cartilage are the best because it gives that sturdy, it's very sturdy and it's pretty straight and you can sculpture that. Okay. And we use, I know in Scotland, they don't use irradiated costal cartilage, I think, but we routinely use in our practice here irradiated cartilage. That's a donor rib cartilage, but they go through a strict sterilization procedure. So no living cells. So there's no chance of body rejecting that. So there's no antibody reaction or anything like that. Okay. So the other thing is if they can ask you what surgery you're going to do in a patient. So you don't need to again go through everything in detail, but if you can come up with a structure, a patient who's got a big, like a saddle deformity, what's your surgical plan? Then my approach, what I would say is I'm going to do this by an open septorhinoplasty approach. My aim is to reconstruct the septum if there is a deviation. Okay. If there's a big hump, I'll do a component dorsal reduction. So reducing the upper cartilage and then the bony dorsum. I will do an osteotomy if there is a bony deviation. And if there's a hump reduction, I would reconstruct the mid-third with a spreader graft. And then depending on the tip deformity, either bulbous or a pinched nose, or under-rotated or over-rotated, you do tip refinement sutures and the grafts materials. Okay, so if you can say that, I think that's more than sufficient. Okay, I'll do an open approach, I'll do a septal reconstruction, I'll do a component dorsal reduction, osteotomy, mid-third reconstruction, and the defined tip refinement. That'll be sufficient. Sometimes they can ask you a question like, a patient who has, some complications, after the surgery. Somebody has done the surgery or you've done the surgery, patient coming in 2 days back to the clinic with a septal hematoma with rhinoplasty, what would you do? Again, you manage the situation. I don't need to go through in detail. I'm sure you're all aware of how to manage the septal hematoma. Or patient coming back, you've done a rhinoplasty for a deviated nose, patient coming after 2 weeks time, the nose is tilting back. What are you going to do? Okay. Again, it's all about being safe here. They're not asking you any perfect answers. They are going to ask you how safe you are. Do you understand? Do you have the knowledge? And do you have a structure in your approach? I think that's what they'll be looking for. Is that okay? Do you have any burning questions? I'm quite happy to answer. No? Gone all silent?
Yeah, looks like.
Yeah. All happy or gone to sleep?
Thank you very much for your talk. It was an interesting one. Thank you very much.
Okay. Good. Okay, that's fine. All the best, guys. Thank you very much.
Pleased to see you.
Bye-bye.
See you. All right. Happy to go for the next one. And my next one will be this one about different topics in head and neck. And I want you guys to let me know if you can see the screen or not. Anybody can say anything? Is the
Yeah,
screen is there?
yeah, yes,
Excellent.
yeah.
Okay. Let's go. So, good evening, everybody. And now we're talking about head and neck, and we have a 40-minute presentation. Hopefully, we'll finish before it, but it's really, really tough topics. We talk through it. So let's start by laryngectomy stations. I did this talk last year, and I think it's been recorded. Let's do something similar with some modifications this year regarding the updates and different questions. So if you face up with a laryngectomy station, the questions you will be asked about if you have this photo in the exam or a clinical scenario like a clinical case. So looks like the patient have a permanent stoma, and because this is like almost over just above the sternum, so it's definitely a permanent stoma for a laryngectomy patient, and you can see an evidence of a scar somewhere, and he has a speech valve in. So things to comment on this station for the exam is, first of all, this is a clinical photo for a patient with a permanent stoma or a permanent tracheostomy with probably a history of laryngectomy, and he has a speech valve in. So that's first of all, like this is the first minute you can answer this. And in nowadays, when we're talking about laryngectomy, we have to know, is it a primary laryngectomy or a salvage laryngectomy? And that would be a good thing if you, in the clinical case, if you are aware about what's the difference between a primary and secondary and salvage laryngectomy in the exam. And this is give you a bonus if you really search for it and talk with the examiner about it. So, if the patient have any skinny changes suggestive of previous radiation, like the skin here is not like very clear and white, it looks like it's darker, or if the patient have a scar of a flab in the chest or in the leg, you can ask the patient about it. Then you search for it, then you know like this is a salvage laryngectomy rather than a primary one. So what is the differences between primary and secondary laryngectomy? Primary laryngectomy nowadays is for a locally advanced squamous cell carcinoma of the larynx or the hypopharyngeal larynx, which is T4A. As we know, T4A is a locally advanced tumor breaching the cartilaginous framework of the larynx, either from the larynx or the hypopharynx. So it could be a laryngectomy or laryngopharyngectomy. Salvage laryngectomy is a patient has received an initial treatment with radiation or chemoradiation, and after that, for a certain reason, he underwent a laryngectomy. What I mean by radiation, radiation nowadays is we giving the patient 70 gray, which is from Monday to Friday, every day for 7 weeks. So like 35 fraction, and every fraction is 2 gray. So this is all 70 gray, 7 weeks of radiation. And sometimes if it's a locally advanced T3, then we have to combine it with an organ preservation protocol. I'm sure that Jay went through this with his presentation, which is concurrent chemoradiation. So we give it either induction chemotherapy, that's a veteran affair, an old one, or concurrent chemoradiotherapy, like giving chemotherapy on the first day and after 3 weeks sessions, and after 6 weeks concurrent with radiation. And after that, with 3 to 4 months, we go for a PET CT. As you see here in the picture, this is a PET CT scan of a patient underwent a chemoradiation, and he had a persistent uptake or increased FGG uptake, which is a fluorinated deoxyglucose uptake. If it's more than 3.5 or 4 SUV volume, you might ask it about this. With a standard uptake volume, if it's more than this, then it means that it's high or a hot uptake or increased uptake. It means that there is still a cancer in, and because of that, the patient will need eventually a salvage laryngectomy. Sometimes we offer laryngectomy on a salvage basis, not because of the persistent tumor, because the larynx are started to be dysfunctional, and can be happening even years after the patient has been treated initially with radiation. And we have to know the main function of the larynx, which is mainly protection. And the main function is protection of the lower airway. So the patient presented with a history of radiated neck for cancer larynx, even T1, T2, and after a few years they start to aspirate and having recurrent lung infection. Then it's worth thinking about this larynx is not doing the job, and we have to remove it to protect the chest. And that's again another salvage laryngectomy, but here for functional reasons. Or sometimes if it's a patient presented really very late as a side effect of radiation with something like this, which is a cartilage necrosis followed radiation called radionecrosis. So this is all example of patients have been radiated, and this is all the skin changes, and this is definitely an indication for doing something like a salvage laryngectomy. Coming back to these photos, it's a T4A, and this patient is a recurrent cancer larynx as well after radiation, and it's very advanced at T4A because they can see the cancer, the squamous cell carcinoma is fungating through the skin. This is all examples of a primary laryngectomy for a T4A, either tracheostomized or not. This is all an indication for laryngectomy. Okay, so what make a difference between primary and salvage laryngectomy in terms of the management, and why when in the exam you have to look for any flap? Why are we doing a flap in salvage laryngectomy? Because the most common complication in irradiated neck is bad healing. And the bad healing here will result into a pharyngocutaneous fistula. And the risk of pharyngocutaneous fistula, it can have a saliva soaking and infection, and the saliva is a very bad enemy to the carotid sheath, which can end up with a catastrophic bleeding with a carotid blowout. So the most common complication following in salvage laryngectomy actually is bad healing and pharyngocutaneous fistula, and has been reported in the literature and with meta-analysis of all the cases that has reviewed the salvage cases. And this is an example of a patient having salvage laryngectomy, and he's presented the second week. Usually, you start to see this patient, the wound is open up, and start to see the saliva coming around the permanent stoma. And like this patient is not doing well, and he had a pharyngocutaneous fistula. Pharyngocutaneous fistula is common in salvage cases compared to the primary one. And this is again something you can be asked in a clinical scenario in the VIVA rather than the clinical case, rather than a clinical case. Pharyngocutaneous fistula is very bad complication of laryngectomy, especially in salvage. And if you can divide the factors that is really involved in pharyngocutaneous fistula, you can divide it into patient factors, tumor factors, and surgical factors. Patient factors: is a patient diabetic? Is a patient have hypothyroidism? Is a patient smoker? Is a patient malnourished? Two of them related to radiation. Usually radiation has mucositis. The patient is not great regarding the saliva and cirrhosis, so he is not very good in terms of the swallowing. And also he had a hypothyroidism, most of them having a certain degree of hypothyroidism. So two factors in salvage cases that can be implicating, and because of that, the risk of pharyngocutaneous fistula is slightly higher. Diabetes and smoking is always is always a common factor, either a primary or salvage one. Tumor factor, usually if the patient has been radiated, and has a persistent tumor, that's a really aggressive tumor. Radiated tissue or radiated neck is not good for healing, because like radiation can kill the cancer and kill the normal tissue as well, reducing vascularity and affect healing. Sometimes if you get to do a laryngectomy, either a primary or salvage, and if you have a close or positive margins, then the patient can be presented later on. It's not immediately when he get discharged from the hospital. Later on, he can develop a fistula. And the question why he had a fistula, late fistula, then we know like there might be a close or a positive margin and end up with a recurrence. Surgical factors as well is important. And usually we are, when head and neck surgeons are really keen to get a very good clear margins. However, the closure, it should be very fashioned to the patient. We shouldn't do a tight closure. If you really have a doubt to put a flap or not, or reconstruct the pharynx because you're taking more, so you have to put a flap rather than to make a tight closure. And again, as we mentioned before, whenever there is bad healing, you have to get a vascularized tissue to cover your closure. It's not enough to depend on the suture closure. You have to augment the closure with a vascularized tissue. And this is why we are doing pectoralis flap as a muscle flap to cover even normally closed pharynx because it's been radiated before. And we want the patient to have a good healing, a better healing following that to avoid pharyngocutaneous fistula. Sometimes, if you have to remove part of the pharynx, you have to reconstruct the pharynx with vascularized tissue. Don't rely much on the healing, especially in salvage cases. So you're looking for a myocutaneous flap, which it could be a pectoralis flap or with the skin over or an ALT, anterolateral side flap. And this is all to prevent that complication, which is a pharyngocutaneous fistula. So whenever you have a salvage case, you have to search for a scar in the chest or in the leg to make sure if this patient has a salvage laryngectomy or is it a primary one. And that can transfer you from being just talking about a pass mark to good pass and start to talk about an interesting topic for examiner. If the pharyngocutaneous fistula happened, what we will do, initial measures will be we can use a hyoscine bromide, like something to decrease the saliva, salivary bypass tube, some sort of long-term feeding, like rather than an NG, which is a big tube for feeding. This is all conservative and dressing, frequent dressing. This is all can be helpful, but in some cases, if it's the duration is more than 3 to 4 weeks, and the field is really soaked. Again, we are very caring about the carotid, and because of that, we have to do something. So basically, we do sometimes 1 or 2 flaps. Like here in this case, we did like a pectoralis flap with the muscle and the skin. And this is a case we did a supraclavicular flap as well, based on the supraclavicular artery to help as well with the muscle. We did a couple flaps, like we did a muscle flap to augment the pharyngeal closure, and also we get the skin covered with a supraclavicular flap. So it's all flaps or reconstruction. You have to mention something about it. You don't need to be so much detailed, but just to keep in your mind, nowadays, if you do a salvage, you have to augment, and the augmentation here is usually by muscle flap. This is an example of an ALT flap. We usually do that for a pharyngeal reconstruction, especially in salvage cases. If you really close the pharynx slightly tight in salvage cases, you have to consider putting a musculocutaneous flap, like an ALT flap. This is like an example of the microvascular anastomosis for these cases. Okay. So the second question will be about a laryngectomy. What's the expectations of this patient will be, and what's the conversation before those patients should be psychologically rehabilitated, nutritionally rehabilitated before by seeing a dietitian. Consider a better route of feeding if the patient really malnourished by big tube of feeding or an NG, and they will usually go for an NG feeding after the operation until like they got a good healing. The third thing, which is very common, which is a respiratory thing, which is a ventilation that's through the stoma. And we are using HME for that to make the heat and moisture exchanger to get the air in with a good temperature and good humidity. And the last thing is the patient's last function of the larynx is phonation. How we restore phonation, how the speech will be rehabilitated after laryngectomy. We have usually 3 options: either electrolarynx, which is something most people don't like, but it could be an initial tool. Electrolarynx can be transcutaneous or transmucosal because the sound got by this electrolarynx doesn't look like normal. It's like a microphonic speech. Other things, which is a cheap way of training the patient to deliver a speech, is esophageal speech. The patient can engulf or swallow some air and try to keep it and try to get it out with a vibration along the pharyngoesophageal segment. Ideally, speech rehabilitation gun is usually done by the third method, which is tracheoesophageal speech, creating an opening between the posterior wall of the trachea or the tracheostomy and actually the posterior wall of the trachea through the stoma, connecting to the esophagus. And through when the air is exhaled, the air rather than and the patient is closing the stoma, the exhaled air will run through this valve into the pharyngoesophageal junction, which is already there, and make some sort of vibration to mimic the normal speech. And for this, we need to have two things. We need to have a very good air, which a good lung support and good manual control over the stoma, and good stoma size as well, and a functioning opening with a functioning speech valve. And the speech valve is could be indwelling or extolling. It's a one-way valve. It prevents the food from coming from the esophagus to the tracheostomy or the trachea, but allows the air to go from the trachea into the esophagus and the pharyngoesophageal junction. And the fourth thing, which is really important in that speech, we have to have a very good tone of the pharyngoesophageal area. It shouldn't be so tight, no stricture or not tightly closed, and also shouldn't be too capacious. It means that there's no tone in it, so the speech will not be good. And because of that, we usually, when we do the laryngectomy, before we closing the pharynx, we do an upper esophageal myotomy. We release this constrictor lower portion of cricopharyngeus muscle that will allow the mucosa of the pharyngoesophageal junction to be very good vibrating. So main factors affecting good speech is good stoma, lung support, functioning TEB or tracheoesophageal prosthesis, which is a one-way valve, and vibrating pharyngoesophageal junction. We know different types of prosthesis, tracheoesophageal prosthesis or speech valve. You might be asked about it. What do you think she have, or the patient have, or he had? So it could be an ex-dowling one or an indowling one. The most common nowadays are indowling provox, which is usually changed by the clinician and done either a primary or a secondary basis. Could be an ex-dowling like a Plumsinger device. It could be ex-dowling or indowling Plumsinger. Um, Depends on the clinician, preference and the unit you are working in, but most units now are using Provox as an indowling speech valve. It could be done primarily in this operation itself when you're doing, and most of our patients nowadays are done by, we used to have the speech valve as a primary insertion, even in salvage cases. And the new, Provox Vega is very simple too to get it inserted with the kit and everything to be inserted into the right area. We have to think about where to put the valve. Usually we create the opening just a centimeter or 10 millimeter from the upper border of the stoma, so it will be easy for the patient when they close the stoma to get the air pushed in through the valve into the pharyngoesophageal area. Second replacement can be done after 6 weeks or maybe two couple of months. Sometimes it's more, depending on if you had a big reconstruction or if it's a salvage cases. It used to be like a secondary insertion. However, nowadays, most of our cases, we do it, even salvage cases are a primary insertion. Any contraindications to the tracheoesophageal valve speech valve insertion? No contraindications. Actually, even like when the patient have a dextry problem, or even if you do a big reconstruction or limited pulmonary function, this is all relative contraindications. Only actually contraindication if when you do urolaryngectomy, if you separated the common party wall between the trachea and the esophagus, we prefer not to put any speech valve because no matter the size you put to the speech valve, it will be incorrect side because you separate the wall, and the valve will be initially good, but later on when the edema and the scarring down that will happen, there would be a wrong size valve, and there will be a problem for the valve. Will be non-functioning valve, and will be a leakage around it as well. Problems with the valve, it could be valve dysfunction, valve extrusion, valve leakage, dysphonia. We don't like to talk much about this, but just to let you know about there might be a problem with the speech valves. And you just need to know something about the causes of central leakage when the valve is not functioning or get an infection in the valve itself. It will keep the valve open. One of the common causes to keep the valve open is a mucus plug rather than a fungal infection. That's the second cause, or the third cause is the valve is not working properly. And if all of this will make the valve widely open and the function of the valve will not be achieved. So no, it will be no one-way valve. So it means that bad speech and also leakage through it. And if that's the case, you have to clean it first with a brush. And if you find any fungal infection, you can use a topical nystatin. Problems around the valve leakage, which is called the peripheral valve leakage, are usually related to the incorrect size in the beginning, or there is a distortion of the esophagus, pharyngoesophageal area above the valve. The distortion can be by a stricture or by a recurrent tumor, or even it could be like the tracheoesophageal opening itself started to widen around if the patient has been radiated before. And we have solutions for all of this. It doesn't mean that you have to remove the valve you or replace it with another one. The safest is to get the valve out, allow the area to heal down nicely, and the patient can be fed at that point with an NG. And after that, you re-establish or you insert a new valve with a new opening from the beginning, rather than just to replace the valve with another size and make the problem sometimes worse. Okay, stoma stenosis management. Sometimes it could be, if you remember a picture of the first patient had very evident sternal end of the sternocleidomastoid muscle, which is not good. We usually divide the sternal ends as well in the laryngectomy to make the stoma not very well, there will be no tension around the stoma, allows the stoma to heal nicely. Don't put many sutures. We usually a single layer of sutures to create the stoma. And if the stomal stenosis happen, you might need to dilate it in the beginning or keep a Lari tube in. However, eventually, if it didn't improve and it's really scarred down, you might consider doing what is called a stomoplasty or a V to Y inset of the skin. Do like a V incision and instead of the skin around inside the tracheal rings. So it's called VY stomoplasty. That's one main topic of our lecture today, one of the main topics of head and neck topics today. The second topic is important as well, but will be shorter and usually related to the neck dissection, which is a chyle leak. And if we want to know a little bit about neck dissection, you have to remove the lymph nodes with a lymphatics or a fibrofatty tissue, could be selective, modified radical or radical. On the left side, you remember there is an important structure which is called the thoracic duct. This thoracic duct carries the lymph from all the body except the right head and neck, right upper limb, and goes from the abdomen to the chest until it's inserted in between the subclavian and the jug on the left side, the internal jugular vein. And because of that, sometimes when you do really a neck dissection, especially in level 4 area, in the left side, mainly in thyroid patients actually, but sometimes in squamous patients, you can injure the thoracic duct. And if you injure the thoracic duct, the best to repair it, to identify it, but not every surgeon is aware. But this should be the case. It should be aware if you do this operation. If there is any clear leakage around this area, and ask the anesthetist to do Valsalva, and he has to repair it with stitches and put a muscle on top. However, sometimes for certain reason, it might be apparent later when the patient starts to feed on the first post-op day, and then the situation will be in your drain, something like that, which is a milky white fluid in your drain. So what's your thoughts? It's almost a chyle leak. You have to say that. Very suspicious of a chyle leak, milky white color. I will send the contents to make sure it's a chyle or not for triglycerides or chylomicrons, and then I will start to manage. Management here, why is a chyle leak is not good thing? Because two factors, local effect of the chyle itself on the healing tissues, so it can leads to a wound breakdown and fistula. The other thing is if it's a high output chyle leak, it will lead to a metabolic and electrolyte imbalance. So you have to fix it. And the way you fix it or the management, depending on the volume, it's a low flow chyle leak, which is less than half a liter per day, then you still can work on conservatively, avoid the fat totally, changes involves the dietitian, and change the fat of the diet from true fat or saturated fatty acids to medium chain fatty acids. Get something to clear the stomach and the intestine to increase the emptying like L-erythritide or somatostatin analog. and correct any metabolic or electrolyte imbalance, and do some good dressings around the area over the chyle leak or the left side of the neck. Sometimes you can put a drain on suction. Can help the things to settle down. However, if it's persistent or if it's a high volume leak, like more than 700 per 24 hour, you have a low threshold to get the patient to the theater, and you will never find the thoracic duct itself, but you will find an area leaking around, especially when the anesthetist is doing a Valsalva. And through this area, you put some stitches and you augment what you have done with a muscle flap. You can use a local muscle flap from the SCM or from a nearby muscle. Usually SCM is fine. And you can use a tissue glue as well, that will help. If all these measures has been failed, there will be a last option to involve the thoracic team to do what is called VATS, which is video assisted thoracoscopic ligature of the thoracic duct to get into the chest and try to ligate the thoracic duct from below. That's a very unusual option. I never seen it, but I heard about it just in one case. Usually, like, you either go with a low flow and it's persistent, go for surgery, or it's high flow from the beginning and it's sorted with surgery. Another topic as well, which is a deep neck infection, and because of we discuss it in short, and so we have to know that the deep neck spaces is the spaces between the different fascial layers of the neck. We have the investing layer, the superficial fascia, which is around the platysma, and we have the deep fascia of the neck. We have an investing layer, which is covering the SCM and trapezius, splitting up to cover the submandibular gland and the parotid. And we have an intermediate or a visceral layer of deep cervical fascia around the midline structures that condensated in around the trachea and thyroid gland to make a pretracheal fascia going to behind the pharynx to get into the pacopharyngeal fascia, and the deep layer of deep cervical fascia, which is here, which is orange in color. It has two layers, what is called an alar layer, which is going all the way down to the diaphragm, and the prevertebral layer, which is around the prevertebral muscles all the way down to the coccyx. And between the fascial layers, there will be spaces, okay? So, and we can make it a simple classification of deep neck space infection into if it's involving the entire neck or a suprahyoid or an infrahyoid. Entire neck, definitely something connected the retropharyngeal space between the skull base and the mediastinum, between the pacopharyngeal fascia and alar layer of deep cervical fascia. This is all entire neck length. If it's something like a true prevertebral or a dangerous space, this is all going to the chest or even going down, because it's in between the layers of the deep cervical fascia, the deep layer of deep cervical fascia. Superficial neck space, which is around the platysma, is going all the way to the neck. And the superficial deep neck infection or a superficial space infection, it's usually what we seen it in rare occasions when we have a patient with necrotizing fasciitis, which is not very good and not very common, but it can happen, and the mortality rate is very high, through which you can see the gangrenous skin and the air under the skin. This is a sort of superficial space infection. Suprahyoid, above the hyoid, we have some spaces as well. This is again the retropharyngeal space. Like, this is the entire length of the neck between the pacopharyngeal fascia, which is an intermediate deep layer of deep cervical fascia, and alar layer of deep cervical fascia. And retropharyngeal abscess is not very common except in children. In children, it's an acute retropharyngeal abscess because in the retropharyngeal space there will be some lymph nodes, which is called lymph nodes of Rouvier, and this is vanishing after the age of 6. But for some reason, with some adenoiditis or severe pharyngitis, these lymph nodes can suppurate and make an acute retropharyngeal abscess, which could be an emergency airway situation in kids. Not very common after the age of 6, and has to be addressed and managed properly, especially from the airway point of view. If you have an acute retropharyngeal abscess, usually the child will be presented with fever, odynophagia, and torticollis. Why there is a torticollis? Because this space is close to the prevertebral muscle, so there will be a torticollis. and the severity of this, because the retropharyngeal space is going all the way down, so you have to drain it for the airway point of view and to avoid anything related and in complication further regarding incidence of mediastinitis. It's unusual in adults, and if it happens in adults, it's usually related to a TB of the vertebrae, so it's actually a prevertebral space infection, or if there is any trauma through the esophageal wall, and this is going complicated with deep neck infections, then maybe at that point it's not very common to have a retropharyngeal abscess in adults. And danger in alar space, and like a prevertebral space, this is all going down. And if it happen, usually something happen in the vertebrae, like a TB or something, it's unusual as well. Um, a visceral space, this is something around the vascular space around the carotid sheath. It's not very common. It could be a complicated deep neck infection if to spread to the carotid sheath, and the layers of the carotid sheath is almost formed by the investing layer and intermediate and deep layer of cervical fascia. This is again something, if it happen, it will not happen isolated. It's usually as a part of multi deep neck space infection. Suprahyoid, we have the peritonsillar one, which is related to severe tonsillitis between the capsule of the tonsil and superior constrictor. And this is the patient we presented with severe odynophagia and trismus, because here we have, we have here, when if there is any retros, there will be a severe swelling. This is close to the retromolar area and the pterygoid muscles as well. And because of that, the patient usually presented with trismus because of the spasm of the pterygoid muscle. And it could be also affecting the swallowing, and the speech here would be like muffled speech or hot potato speech. And if you've seen that, the patient hardly opens the mouth, and you have to make sure it's a peritonsillar abscess by putting a needle in the most prominent point and make sure there is a pus coming out. If it's a dry tab, then treat it like a severe tonsillitis. And if there is a pus, then you have to think about draining it, and you usually drain it under local. What other deep neck spaces that can be affected? Submandibular space, and the submandibular space can be either bilateral, which is called the Ludwig's angina, which is a bilateral submandibular cellulitis. That's again between the investing layer of deep cervical fascia and floor of mouth. And the risk of Ludwig's angina here is because like this trapped infection or a cellulitis can put a pressure on the tongue and prolapse the tongue backward. And this can affect the airway. So it's again a suprahyoid deep neck space infection, a bilateral submandibular cellulitis, and needs to be treated. And there is like here is like rather than an abscess, it's a gas in both sides of the submandibular spaces. Needs to be treated immediately because of the airway risk, as we mentioned about pushing the tongue posteriorly. So that's a life-threatening situation. Parapharyngeal abscess is another a deep neck space, and suprahyoid as well. And it's again like a deep neck space infection because it's between two fascia. The fascia which is around the masticator muscles, and the fascial layer, which is part of the investing layer of deep cervical fascia around the parotid and masticator muscle, as a buccopharyngeal fascia, which is again an intermediate deep cervical fascia. And because of that, there is a potential space here, which is called a parapharyngeal space. This space is bounded by masticator muscles in front, laterally mandible and parotid. Posteriorly, medially, it's a buccopharyngeal layer of deep cervical fascia, and posteriorly, it's a deep layer or alar layer of deep cervical fascia. And because of that, it can be easily connected to the retropharyngeal space, could be connected to the pharyngeal mucosal space, could be connected to masticator space, could be connected to parotid or submandibular space. So the parapharyngeal abscess can happen for many reasons, either severe tonsillitis or pharyngitis, could be as a part of multi-space affection, if like there is a submandibular or a parotid space infection, or if there is a masticator space infection regarding the teeth, or it could be affected as well and can affect and can complicate. Parapharyngeal abscess can be extending to the retropharyngeal space as well to cause a parapharyngeal and retropharyngeal abscess. What's the structures in the parapharyngeal space? So it's an inverted pyramid between the skull base and the hyoid bone, bounded medially by the pharyngeal, buccopharyngeal fascia, lateral by parotid fascia, anteriorly masticator muscles, and posteriorly is deep cervical fascia or deep layer and retropharyngeal space. Uh, Components pre-styloid and post-styloid because there is a fascial here sling tensor vascular layer between the styloid and the pterygoid called stylopharyngeal component aponeurosis of Zucker candle, and through which it's another Zucker candle other than the thyroid Zucker candle, and it's divided into pre-styloid space, usually related to the deep lobe of parotid, and post-styloid space where it has the big vessels and lower fourclean nerves. Communications, we said about parotid, masticator, peritonsillar, which is related to the pharyngeal mucosal space, submandibular, and retropharyngeal. We usually you don't have this to be asked in the exam about masticator or temporal spaces, parotid space. So what's the reasons for a deep neck infection? We mentioned about tonsillitis. It can cause tonsillar, peritonsillar abscess or parapharyngeal abscess. Other than the tonsils, there will be a teeth that can cause Ludwig's angina, submandibular cellulitis, because it's inserted above the mylohyoid line. And actually, submandibular or Ludwig's can be complicating later on or can be extended to the parapharyngeal space, as we mentioned earlier. Sialadenitis, if there is severe infection in the salivary gland, that can result into an abscess. Drug abusers and HIV, and also trauma, if there is any trauma that can cause a retropharyngeal space. That's all. The trauma can be iatrogenic as well. This is all. And in children, you think about if there is a recurrent deep neck infection, think about there might be a congenital branchial cyst that keep infecting every now and then and presented with a recurrent deep neck infection. Presentation usually by sore throat dysphagia, airway problems. That's the most important thing. And for a retropharyngeal abscess, don't forget in children torticollis. And we have to treat the deep neck infection. Admit the patient. Start with looking for the airway, assess the airway and neck, and use a flexible knee endoscope to make sure like the ABC has been achieved, airway breathing circulation management as a part of MDT with an infection control, infection disease department or microbiologist on call, and also emergency or an ITU and anesthetic as well for an airway risk. Scope the patient because the most common complication of deep neck infection are airway obstruction, especially if it's a parapharyngeal, retropharyngeal, or Ludwig's angina. The second common complication, if it's not being treated, is a mediastinitis if the infection extended to the chest. And here we have more than 50% mortality, like a 70% mortality, and multiple space involvement as well. Who get complications? People have systemic problems or older patients or diabetics. Imaging, usually we go for a CT scan. X-ray has been advised in kids. There will be a straightening on the cervical vertebrae because of the torticollis and widening of the retropharyngeal space. Not many people now do an X-ray for even kids. CT scan is our favorable, with contrast is our favorable investigation for the neck and chest. You have to make sure when you admit the patient, get blood, check for full blood count and kidney functions as well before doing this scan, and make sure the airway is stable enough before considering doing a CT scan. Otherwise, you have to sort out the airway first before getting a CT scan with contrast. And this is an example of a parapharyngeal and a retropharyngeal space infection. Antibiotic therapy, usually discuss it with a microbiologist as a broad spectrum antibiotic IV. First, it might be more than an antibiotic combination, and always think about airway. By doing a FNE or flexible nasal endoscopy, You look for the airway and how bad it is, and you have a discussion with the anesthetist if you need to sort out the airway immediately or not, and have low threshold if it's a Ludwig angina to get the patient to the theater before even getting worse, because it's an airway emergency, because this patient will deteriorate sooner or later, and you don't like to be in an emergency situation. You have magic techniques about fiber optic intubation, or sometimes you need to have a front of neck access with tracheostomy. Surgery regarding the drainage itself, it's the easiest portion depending on the space involved. You either go transverse neck incision. If it's a submandibular, usually 2 fingers below the angle, from angle to angle if it's a Ludwig's, one side if it's a submandibular. If you're talking about a parapharyngeal, you have to go behind, you see the digastric and go behind it to, and behind the submandibular gland to get actually into the parapharyngeal space until you feel the styloid process. This is all by finger dissection. Retropharyngeal space, you go a little bit down, transverse neck incision at the level of the cricoid cartilage. Try to retract the SCM laterally, cut the omohyoid and control middle thyroid veins if you have any, and then put your finger in the retropharyngeal space between the midline structures and put a drain. And that's almost a brief idea about how to drain the deep neck spaces. Some, if it's not big enough, like in parapharyngeal, you can consider conservative management, and some people as well will go for repeated ultrasound guided aspiration as an option before considering a surgical, like a definitive surgery. Last topic is the parapharyngeal space tumors, and we discussed about the parapharyngeal space and the boundaries of it, and definitely it's easier now to talk about what you expect in terms of the tumors. Could be a pre-styloid, something coming from the deep lobe of parotid, or the fatty there is like lipoma. Post-styloid, it usually come from the big vessels or the lymph nodes around it, or actually the paraganglia, which is a neurocrest cells around the big vessels. So it could be schwannoma, neurofibroma, or paraganglioma. That's a more common, the most common tumors that arise in the parapharyngeal space. Most of them are pre-styloid, 80%, and 80% of the pre-styloid are benign tumors, pleomorphic adenoma, deep lobe of parotid. And how you know that it's a pre-styloid, if it's widening the stylomandibular area, that means that it's in front of that tensor vascular fascia, so it's like a dumbbell shaped. It's widening the stylomandibular tunnel, getting from the deep lobe into the parapharyngeal space, and you always push the vessels posteriorly. And then you can know that by doing an MRI. A post-styloid neurogenic tumor, schwannoma, neurofibroma, and salt and pepper appearance. You see here, this is like a very this is like a T1 with contrast and MRI, and you can see it push the vessels anteriorly. So it's a post-styloid and no widening of stylomandibular tunnel. So it's a post-styloid, and if it's homogeneous like this, it is a schwannoma. If it's like pushing the vessels anteriorly and has like some sort of salt and pepper appearance, it means that it makes it intensity. It's a paraganglioma, which is actually common to have a vagal paraganglioma. It's not that common compared to the pre-styloid, but it can happen. Compared to the schwannoma, it's more common, vagal paraganglioma. And you know, paraganglioma is a MDT management with multiple specialties, skull-based MTD involving a paraganglioma endocrinologist, genetist, and you know all this topic about paraganglioma, carotid body tumor, either or jugular paraganglioma or a vagal paraganglioma. This is a big topic. You need to study the genes involved. You need to involve many teams as well, and mostly most of them will go conservatively because they are small tumors, slowly growing, make the operation can destroy more nerves compared to the actual presentation. So you need to read a little bit more about paraganglioma and how to manage. Clinical symptoms usually started by some sort of neck swelling and some cranial nerve affection. CT scan is important, but the MRI is actually the best study because it give us an idea about the relation pre-styloid, post-styloid, and give you more characteristics about the kind of pathology you're dealing with. Angiogram is only considered if you consider operating on a paraganglioma, and the treatment approaches here, if you consider surgery, will be either transparotid approach if you come from the deep loop of parotid. Sometimes you can go for a transcervical approach, but the best is to go between, like you use both approaches, cervical-parotid approach to get the parotid approach, get the facial nerve and go down to the neck as well to get everything exposed, cut the posterior bay of the gastric and stylohyoid muscle, and you can get easily into the parapharyngeal space. Okay, that's it. I hope that it will cover everything. Any questions so I can help with?